Croup in the Pediatric Population by Caitlin Albright, Rachel Griffin, Nicole Klosterman, Brooke Rader, and Kara Thompson. The major types of croup are laryngotracheobronchitis, or LTB, acute spasmodic croup, and bacterial tracheitis. The disease process of croup starts with an upper respiratory infection. Parainfluenza, RSV, influenza, and strep are common causes. Mucosal inflammation and edema cause narrowing of the airway. The epiglottis and trachea swell, resulting in restriction. The airway of the pediatric patient is 3 times smaller than that of an adult. Additionally, the larynx of a child is more flexible and susceptible to spasm. As you can see from the picture, a healthy, dilated airway allows air to travel through with ease. However, the inflamed, constricted airway in croup makes it difficult for the passage of air. Croup is characterized by cough and symptoms of respiratory distress. The cough is sudden onset of a harsh, metallic, or barky cough or hoarseness. Signs and symptoms of respiratory distress are substernal or suprasternal retractions, agitation, pallor or cyanosis, increased heart rate, extreme restlessness or listlessness, hypoxia, nasal flaring, and inspiratory stridor. The duration of the illness is typically 3 to 4 days. This short video provides an example of inspiratory stridor at rest, one of the hallmark symptoms of croup. Non-pharmacological treatments for croup include taking the child out to cool, moist air, such as Nebraska in the summertime, sit in the bathroom with the shower running and breathe the steam, hug, back rub, or sitting on parents' lap, reduce stimuli such as loud noises and bright lights, read a favorite story, sing a song, or offer a toy for comfort, maintain adequate fluid intake, position in upright position, and getting plenty of rest. Pharmacological treatments for croup include oral dexamethasone, oral prednisone, nebulized budesonide, nebulized salbutamol. These are all steroids to reduce inflammation. Humidified oxygen and antibiotics are indicated for treatment if underlying cause is bacterial. All of these treatments are appropriate for an outpatient basis. Racemic epinephrine is used to treat transient symptoms. Patients should be monitored for rebound stridor for at least 3 hours after administration and is not appropriate for outpatient use. In this picture, we see a child receiving a nebulizer treatment being kept calm and comfortable in the arms of a parent. NCLEX question 1. A child is brought to the emergency department and is diagnosed with laryngotracheobronchitis. What would the nurse anticipate the provider to prescribe for the child? Select all that apply. A. Oral prednisone. B. Oral dexamethasone. C. Nebulized albuterol. D. Nebulized budesonide. E. Oral penicillin. Answer 1. A. Oral prednisone. B. Oral dexamethasone. D. Nebulized budesonide. Oral and nebulized steroids are given to reduce inflammation in the airway. Albuterol is a bronchodilator that will only affect the lower airway. Croup is an upper airway disorder. LTB is viral, and therefore antibiotics would not be appropriate. NCLEX question 2. Which interventions should the nurse include while caring for the child with croup? Select all that apply. A. Monitor hydration. B. Monitor respiratory status. C. Run to get a crash cart if the child goes into respiratory distress. D. Encourage the child to lie prone. E. Administer humidified oxygen if ordered. Answer 2. Correct answers are A. Monitor hydration. B. Monitor respiratory status. And E. Administer humidified oxygen if ordered. A, B, and E are appropriate interventions for the child with croup. C and D are incorrect. A child in respiratory distress should never be left alone, and the nurse should call for help. A child who presents with croup should be encouraged to sit upright, head of bed greater than 30 degrees, and in a supine position. Do not force a child in tripod position to lie down. Upright positioning will help facilitate respirations. Prone position does not aid with respiratory function and may cause smothering.